Hello, I'm Dr. Angela Long, and I'm going to talk to you about opioids, in particular over-the-counter opioid misuse. So, what are the recent statistics? So, England is experiencing higher than expected rates of mortality and morbidity from opioids. Where we know a lot about prescription opioids, the extent of over-the-counter opioid misuse is currently unclear, as data on codeine sales are not publicly available. But there is evidence that over-the-counter opioid use is a growing problem. For example, survey research over a period of 20 years in Scotland with community pharmacists has shown significant increases in over-the-counter drug misuse over the years, but it's codeine-based products that are reported as the most commonly misused over-the-counter drugs. Because they can be bought over the counter, these medications are often considered safe, and people can be unaware of the risks of continually taking analgesics containing codeine. So, which over-the-counter opioids are most frequently misused? So, medicines containing opioids, such as codeine, are classed as P medicines, which means they must be sold with a level of consultation that includes advice for use of not more than 3 days and warnings for addiction, and can only be sold when there's a pharmacist on site for supervision. Codeine is classed as a weak opioid, and it's contained in over-the-counter products like cocodamol and Nurofen Plus. Globally, it's one of the most widely available and commonly used opioids. The UK market offers various products containing codeine, with tablet formulations being the most common. 3 out of every 4 products contain paracetamol in combination with codeine, such as cocodamol. More expensive products such as sulfadine also contain caffeine. And products such as Nurofen Plus that contain ibuprofen and codeine are also popular. The availability of these products over the counter provides an opportunity for people to self-medicate and self-manage their pain. However, products that contain codeine can lead to addiction and dependence when used incorrectly. With regular or excessive use, they can quickly lead to pharmacological intolerance, creating a need to increase the dosage to achieve the same desired effect. So, are there specific populations or demographics that are particularly vulnerable? Now, it's important to note that managing over-the-counter opioid misuse is a complex issue, as misuse can take various forms. It can include exceeding recommended doses and duration, perhaps buying over-the-counter codeine to top up existing opioid prescriptions, dependency through medical reasons, using codeine to stave off opioid withdrawal, for example, through deprescribing, or using it for euphoric effects. Research has found that there isn't a profile of a typical misuser, and there are a variety of clinical profiles that misuse codeine. Those who experience codeine dependence are reported to be different to other opioid-dependent groups. They often have no history of other substance abuse, such as alcohol. They do not necessarily recognize a problem or associate themselves as drug addicts. And when approached about an issue with their use, they can feel stigmatized. Cooper used the term respectable addicts to describe this group, and reported that most people start using codeine for genuine medical reasons, including managing physical pain such as joint or back pain, dental, menstrual, or post-operative pain. The continuation of taking medication can develop into an addiction, and this secretive and hidden group of individuals perceive themselves to be normal members of society and as respectable professional people. So, what are primary care challenges that healthcare professionals face when trying to deprescribe opioids? So, discussions around deprescribing may induce fear of worsening pain or withdrawal symptoms in patients. If we consider the impact this might have on over-the-counter purchases, there's no way of managing it if people turn to this option to try and replace their medication through deprescribing. People will often visit multiple or rotate different pharmacies to gain a plentiful supply. The preferred treatment for chronic pain is non-pharmacological intervention, and this can include things like psychological interventions such as cognitive behavioral therapy. But one of the drivers of prescribing opioids for chronic pain is that it's difficult to ensure engagement with these types of interventions and hard to access for people in deprived areas in England. There's a lack of alternative pain management resources, especially non-pharmacological support, so support for exercise, physiotherapy, or psychological services. Where these are available, they're often private with a cost attached, which may not be feasible for many people in lower socioeconomic areas. If we consider best practice for supporting patients through opioid deprescribing while managing their pain, we need to remember that deprescribing opioids is not just a clinical task. It's a deeply personal, psychological, and social process. That's why a biopsychosocial approach is so important. It shifts our thinking from removing medication to understanding the person behind the prescription. Biologically, chronic pain often persists despite opioid use. Non-pharmacological treatments such as lifestyle behavioural changes may take a little time to see improvements, so support with gradual tapering and continued support for self-management strategies is important. Psychologically, patients may have a fear of pain, have anxiety, low mood, and trauma histories that all can intensify pain. Opioids can sometimes be a way of coping emotionally, so deprescribing without mental health support risks failure or distress and may be a driver to seek over-the-counter solutions. Shared decision-making and co-design plans that address the patient's goals can better support people towards better self-management. And socially, social isolation, work-related stress, and financial hardship also affect pain and recovery, and recognizing these pressures helps build more compassionate, realistic plans. And finally, promoting active self-management is key, not as a fallback when medical options run out, but as a powerful, proactive approach in its own right, supporting people to engage in pacing, physical activity, mindfulness, and peer support helps them to build confidence, regain control, and live well alongside pain. This is how we move beyond medication, by investing in people and not just prescriptions.